on telemedicine for obesity management, a temporary or long-term solution. Next slide, please. I am Joseph Proietto. I'm a professor of medicine, emeritus professor of medicine from the Department of Medicine at University of Melbourne, based at Austin Health, and I am chair of the Clinical Care Committee for World Obesity. Next slide. Just some housekeeping points. Please use the question and answer function to post comments and in particular to ask questions of the panel. The recording, this webinar will be recorded, and then the recordings, slides and certificate of attendance will be circulated to the attendees post-webinar. Next question. Next slide. This is the agenda. There's a brief welcome and introduction. Then I will talk about COVID-19, the status and the rise of telemedicine. Dr. Rodrigo Alfonso Carlesi will talk about the protocol for a successful virtual obesity consultation. Dr. Agbo Udinachi will talk about what are the benefits and challenges of telemedicine for obesity management. Mr. Mazin Al-Fulaiti will talk about the patient perspective. And then we will have a panel discussion where there'll be an opportunity for attendees to ask questions as well as take part in the discussion. And we will finish with some final remarks. Next question. Next slide, please. So this is to introduce the speakers. Dr. Agbo Uridinachi is from Nigeria. Dr. Rodrigo Alfonso Carlesi from Chile, and Mr. Mazin Fulaiti from Oman. Next slide, please. Now, this is a true pandemic. We've had one before, if you recall, the Spanish flu after the First World War. So far, it's assessed that there have been 7,500,000 people infected with 421,000 deaths. And the number is still rising steeply. Next slide. Why has COVID-19 disrupted the world so severely? Well, firstly, it's very contagious. It spreads very easily. It's able to cause severe respiratory infection. It has a slightly higher mortality rate than influenza virus. There's no vaccine yet for coronavirus, and we don't have effective antiviral medications to treat it once a patient is infected. Next slide. So who is at increased risk of death from COVID-19? This is well known. People aged over 70 years of age, patients who are immunosuppressed, say transplant patients, for example, patients with severe illness of any type, and also patients with obesity. A recent study from Mexico implied that not only are patients with obesity more susceptible, but that they're not more at risk of death, but they're more susceptible at getting the infection. Next slide, please. So how does obesity increase the risk of death from COVID-19? Well, obesity is associated with decreased respiratory reserve volume, functional capacity, and respiratory system compliance. In patients with increased abdominal obesity, pulmonary function is further compromised in supine patients by decreased diaphragmatic excursion, making ventilation more difficult than usual. In addition, there's increased inflammatory cytokines in obesity. Obesity is an inflammatory state, and which could contribute to the increased morbidity associated with COVID-19 infections. Next slide, please. So in the absence of effective treatment for COVID-19 and higher risk of death, how can we continue to treat our patients with obesity without putting them and us as clinicians at risk? Next slide. So is telemedicine the answer? What is telemedicine? Telemedicine or telehealth is the distribution of health-related services and information via electronic information and telecommunication technologies. It allows long-distance patient and clinician contact, care, advice, reminders, education, intervention, monitoring, and remote admissions. Does it work? How do we set it up? What are the pros and cons of practicing telemedicine? And what role will telemedicine play in the post-COVID-19 world? These are some of the questions we want to answer tonight or today with this meeting. Next slide, please. It gives me pleasure to introduce to you Dr. Rodrigo Alfonso Carlesi, as I told you, from Chile, who's co-director of the Center for Advanced Metabolic Medicine and Nutrition and president of the Chilean Atherosclerosis Working Group Corporation in Chile. And he will talk to us about the protocol for a successful virtual obesity consultation. Dr. Carlesi.
Thank you very much, Joseph. Good morning from Santiago de Chile. I would also like to thank World Obesity Federation for the opportunity to participate in this very interesting webinar and discuss and share experience with our speakers about telemedicine for the management of our patients living with obesity. Well, some important points that were pointed out before by Joseph. First, obesity is an important risk factor in increasing the severity and mortality of COVID-19, and we have recent data published from the UK showing that death from COVID-19 was strongly associated with obesity, among other factors, of course. And also we know before that this effect is even worse on younger patients with obesity below 60 years old. Furthermore, patients living with obesity present other associated comorbidity like hypertension, diabetes, that of course are risk factor for severity and mortality of COVID-19, but also require treatment and long-term follow-up. And in addition, isolation produces anxiety and mood changes in many patients, influencing eating habits, increasing alcohol consumption, and reducing physical activity, all of which have important consequences for patients living with obesity. Next slide, please. Well, the impact of pandemic and subsequent isolation of medical consultation can be observed in this slide with data from Chile. You can see that the increase in the number of active cases in the left, this is in a couple of weeks of May, is accompanied by a reduction in medical consultation. You can see on the right of the slide. In the case of appointments for nutrition and diabetes control in the red line, the reduction was up to 90%. The next one, please. What can we do during this period to improve the control of our patients with obesity and promote their checkup during isolation and after? But probably telemedicine is the solution. Here you have an example of one patient request. This is in Spanish. I translate it on the right in English. I will read it. Dear doctor, I wanted to ask about the possibility of restarting my treatment. Each day in quarantine is getting worse and it's affecting my food intake. I have continued to exercise, but with reduced intensity and frequency. I don't want to neglect my weight. Let me know, please, the step I should take. Unfortunately, I don't have scale at home. So you can see the patient has his objectives. He is care of his weight and he wants to restart treatment. He's concerned about the quarantine and the effect of the quarantine in food intake and in the physical activity. He's trying to be proactive, asking what are the next steps to do. And barriers is that he doesn't have a scale at home. The next slide, please. Well, I think that one of the first things to do is to identify barriers, especially for telemedicine in our patients living with obesity. Probably they are not different than other disorders. They are related to connectivity. This is, for example, access to internet. It depends on the area where you live. Webcam, if not all the computers have webcams. Previous experience with telemedicine, other consultation with other disorders, and the platform used by the patient. There is a transition and adaptation to telemedicine. There are people that they don't like telemedicine and prefer in-person consultation. In my experience, around 20 to 30% of patients prefer to wait to face-to-face. Others that they don't have experience and they don't know how to do it. So we have to explain very well to them. And others probably that will have an excuse to avoid checkups and delay the controls. You know, it is not uncommon that some patients gain weight and decided to wait until they lose weight again for the next consultation, thinking that the doctor or provider will criticize them. And this is not good for them. In some cases, we need to identify a collaborator inside the family to help in the process. And this is very useful for elderly people and children. Patient expectations is what the patient expects from the consultation, how will be the interaction. It is different if it is the first consultation or is a control, the same patient and the same doctor. The goals and the satisfaction with telemedicine. We need to trust in the information that the patient will give to us. We require time, enough time. Remember that the first minutes of connection are usually dedicated to solving technical problems. The video works, the audio, I don't hear you, I cannot see you, etc. And of course, the facility should be a very comfortable place. And there are other technical barriers related to consultation, like in this patient scale, measurement tape in case, blood pressure sphygmomanometer availability, and their correct use. And others, we can include cost and reimbursement. Patients want to know if it works the same as face-to-face consultation. The next slide, please. So how can we do or have a successful telemedicine consultation with patients living with obesity? We need to be very proactive. I recommend prior to consultation, if possible, make a contact with the patient. Any media is good, through phone call, text message, email, WhatsApp, any media, and explain the transition from face-to-face to online consultation, identify the barriers and what we need for the consultation. We need the weight, blood pressure in case, list of medications the patient is taking, and if the patient has blood analysis, more recent if possible, they can send by email. We recommend that other teams members such as dietitians and psychologists should also participate in the control. Find out which platform the patient uses and feel more comfortable, and any platform works. It can be Zoom, Meet, Team, FaceTime, WhatsApp, also a phone call. Invest enough time and make the patient feel comfortable and confident. A good experience improves the next consultation. And establish an outline and protocols, including quality assurance model with feedbacks. Feedbacks are very important for this, and satisfaction surveys. Next slide, please. Also, we have to promote physical activity, and this is an opportunity for patients that don't want to go to the gym, are not motivated, or usually don't have enough time. There is a recent survey through Facebook that has shown that women doing exercise 3 or more days in a week increased from 36% before the crisis to 70% during the pandemic. And interestingly, 44% referred that they will continue practicing telematic physical activity after isolation. So this, I think this is a very good tool to promote physical activity. Also, we recommend online support with a dietitian to reinforce dietary habits, to teach how to read food labeling, to send recipes through email, etc. We have Facebook, there is a lot of information through Instagram. Also online psychological support to manage stress, anxiety, how to face isolation, and also to establish behavior change goals, reinforcing the physician recommendations. Avoid stigmatization. There is a lot of memes circulating through social media, WhatsApp, etc. And we have to take care that our patients with obesity do not receive this kind of memes. Educate patients on how to filter information online. There are a lot of websites with fad diets and wrong information, and it's important that we have to teach our patients how to read it and how to get the correct information. And establish a treatment plan for the patients, including all the above, plus prescription. Now it's easier because we can send the prescription via online. Access to medication, also it's easier now than before because there is home delivery from most of the pharmacies. And the next consultation, if it will be face-to-face or telemedicine. And the next one, please. So what happened in some countries, or LATAM countries? Well, pre-COVID-19, most countries have been implementing different regulations for telemedicine in public and private health system, probably before 2016. It's well implemented for teleradiology, for ECG, etc., teledermatology. What happened with COVID-19 in this period, in the last 4 or 5 months, is that the COVID-19 accelerated the process. And you can see here some news from Chile in the left, Brazil, Argentina, that different governments regulated the use of telemedicine during pandemic. In the case of Chile, also including nutrition consultation. But most of them are given as a temporary solution. It's during the alarm period. So what will happen post-COVID-19? This is what we'll be discussing in the next minute. I think that telemedicine is here to stay, that it will not replace face-to-face consultation, but we have to use technology to support our patients. And probably our patients will decide what modality will be better for them in a certain time, especially those living in rural or other geographical area or have limited mobility. Thank you very much.
Thank you. Thank you. It's my pleasure now to introduce Dr. Agbo Uridinachi, who is a consultant community health physician and a fellow of the West African College of Physicians, and is the president of the Obesity Society of Nigeria. And she will talk to us about what are the benefits and challenges of telemedicine for obesity management. Dr. Uridinachi.
Thank you, Joe. I'll be discussing the topic on the benefits and the challenges of telemedicine with Nigeria in perspective. Just a little global overview that the global confirmed cases of COVID has been rising and the deaths also have been rising. And just shows us that COVID-19 is here to stay. And even in Nigeria, our confirmed cases have been rising too. We have, as of yesterday, 14,554 cases with 387 deaths. And since COVID-19 came into existence, it has brought enormous changes in the healthcare domain. We've seen that a lot of people had canceled appointments, canceled elective surgeries and all that. And it calls for us to look for alternative locations to give healthcare. And virtual medicine could be one of the answers. Next slide, please. And when we talk about telemedicine, even in Nigeria, we've been doing a bit of that. We sometimes we consult and we send text messages, we use audio, we use emails, still messages, but we've really not started using the video conferencing in giving teleconsultations. So it's actually good that this topic is being brought to light to see if there are ways we can institutionalize telemedicine in our health system. Next slide. We know that obesity interventions, they come in various forms. We have the population-wide interventions, we have the lifestyle and behavioral interventions, the pharmacological interventions, and then the surgery. And then having seen all these interventions, we believe that some of these interventions could be carried over to the virtual world. Hence, our clinic location becomes our videos and the virtual world. Next slide, please. Some obesity care teleconsultation services we could carry out include the patient education. We could use it to educate our patients on so many things that pertain to obesity. We can do our prenatal, natal, and postnatal weight management, pediatric obesity management, the elderly patients' weight management, post-surgical care after obesity surgery, the management, the lifestyle modifications in chronic illnesses, even medication adherence and adherence to certain routines like your exercise and your portioning and the diet and the rest. So adherence to medication is key, and we can use the telemedicine to follow up a patient on all that. And then even in the meal planning, these are certain activities or services plus others that we could move over to the virtual world. Please, next slide. And I always like for us to realize that there are levels of the health system. We have the macro level, the meso level, and the micro level. These are all the levels of the health system. The micro level involves the individuals in the health system and the interactions between them. So we have the patients, the healthcare professionals, all working and interacting in the micro health system. And then when we talk about the meso health system, we're looking for all the organizations that function in the health system, the hospitals, the home health, the school health, the mobile clinic, the mobile health clinics. And then we talk about the macro health system. These are the big wigs that control the meso and the micro health system, our insurances, our policies, and the big organizations. And then we need to understand that at the different health system, the benefits of telehealth spans through all these health systems, because we all have a part to play. The macro systems have a part to play in ensuring that we have insurance policies that even when a patient attends the telehealth clinic, that the patient will be covered with insurance. And then provision of guidelines and policies in patient management, and then protocols for patient management through telehealth. And then the macro level is also involved in ensuring there are partnerships formed that will encourage the growth of telemedicine in our health system. And then at the meso level, we look at our hospitals, the private clinics, the tertiary clinics, the primary healthcare centers, the school health, our mobile health clinics. Are there ways we can institutionalize telehealth into their practices, and then the patients and the healthcare professionals? So the benefits of telehealth spans through all the levels of the health system. Please, next slide. So we look at the benefits to patients. For patients, so many research has shown that telehealth has improved adherence to routines and medications, and it has improved quality of care. It has improved access to healthcare, reduced missed appointments, zero travel times. You do not have to travel. And for mothers that have babies, they don't have to worry about carrying their babies and coming to the hospital. And it has reduced patients' waiting time in the hospital. It's also cost effective and very convenient. Right at the comfort of your home, you can see a doctor. And because certain partnerships that exist in remote areas, it has helped to reach underserved populations. Next slide, please. And then for the healthcare professionals, it's actually a way of revenue generation and also provision of income for the healthcare practitioner. And it's been used for professional education, for research, and reduced the patient burden in the hospitals. It has also improved patient education on the side of the healthcare professionals. Next slide, please. Then for the health system, we project that telehealth will help to improve our health indicators. Yeah, and then it will help in disease surveillance and early detection. And overall, it will also lower healthcare costs. Next slide, please. Next slide. And then we have the challenges. We also look at the challenges based on the levels of the health system. At the macro level, we know that everybody is not insured yet. We have the informal sector that is yet to be covered by the insurance, even though the formal sector, still not everybody is making use of the insurance policies that we have. So lack of insurance, lack of partnerships for telemedicine. In the developing world, we need such partnerships that could help to ensure effective telemedicine communications. And then poor health funding. It's been always there in developing countries. And then poor internet network. And at the meso level, we just have unavailable telemedicine services in the institutions. And at the micro level, we think of the awareness, the knowledge of both the patients and the healthcare professionals on the use of telehealth services. And also at the background of all this is the poor health-seeking behavior of the developing countries. Next slide, please. I would recommend that, having seen that, the healthcare environment is evolving. COVID-19 has come to stay, and a major way of being prepared to handle this next level is to institutionalize telehealth as part of our health institutions to serve a majority of the citizens that will opt for it, and to train healthcare professionals, create awareness on the use of telemedicine, and build partnerships for telemedicine. Again, is to link up policymakers, telehealth developers, and the end users. If we do not create this linkage, not much will happen. But with the linkage, it will encourage the use of telemedicine. It will also ensure that there's sustainability to whatever has been started in the field of telemedicine. Thank you all for listening. I'll still hand over to Joe.
Thank you very much. And it now gives me pleasure to introduce Mr. Mazin Issa Habib Al Fulaiti, who's the patient representative. He's a mechanical engineer, the father of 3 boys, and he was born in Muscat, Sultanate of Oman, and he's the patient representative who will give us the patient's perspective. Mr. Al Fulaiti?
Yeah, good afternoon. My name is Mazen, and I'm a patient of obesity since 2017, as you can see on this slide. Started my journey in 15th of July up to till today. I'm fighting obesity, and from a patient perspective view, we are facing. We have 2 sides of it. The first side is, as a patient, we need to go. Most of our patients, they want to be face-to-face and to meet the doctors. And due to this pandemic situation and the quarantine in some of the area, it's become impossible, as the doctor mentioned before. And by the increase of the number of people who is getting infected by COVID-19, we found it's really difficult to visit those people. However, the telemedicine is one of the best solution to sort out this issue. On the other side, some of the patient, they want to be part of the telemedicine, but there are lots of difficulties, which is some of them is the coverage of the internet on those area, which is, as the doctors mentioned before, there are some laptop doesn't have cameras, and even there is no coverage. There is and the distances, the appointment, which takes long time to be cover. I mean, to cross and cover. So telemedicine will be one of the best solution, and this is what I'm doing also with my webpage. I mean, I'm trying to convey my knowledge with my experience to the patients, and to convince patients to go to go by technology, because technology nowadays is it's available, and it's easy to access. The other part, which is the testing part, which always is an issue, that it's a must. I mean, we should have that tested face-to-face and physical test. But still, there are some solution, which is you don't have to approach that particular healthcare center to do it. By going to the nearest healthcare centers and doing those tests, and you can send it by your email to your doctors. You may solve lots of hassle and trouble to those doctors, and to avoid all this interfacing. And so I just want to show that I started the page, my pages with 100 followers, and now 15,000, because there are 15,000 followers I have, because I can see that the technology is the solution. And it's because it's easy access to the people. Mostly they are accessing it at their home and while they're comfortable, instead of facing the travel to the clinic. And now, due to the pandemic, even the appointment, it starts being, instead of 2 months, to become 4 months or 5 months, from the patient perspective. This is what I want to share, and I'm really glad and grateful for the World Obesity Federation to allow me to share my experience with them. Thank you so much.
Thank you very much. So we're now going to have a 30-minute discussion on, is there a role for telemedicine in the post-pandemic world? We have some questions already from the audience. Dr. Khalezi, first of all, do you have a systematic way for appointments and follow-up, and can you share your experience?
Yeah, that's a good question. Yes, we have in our center a systematic way for appointments, but I think that first of all, what it is necessary, because we have to face this problem very quickly. You know, we didn't have enough time at the beginning to be prepared for this kind of telemedicine. So first we have to announce through all social media, Instagram, Facebook, emailing to our patients that we will move from face-to-face to telemedicine during a period of time, during the pandemic. So it was a very quick process. And then every patient can make their own appointments directly through the electronic records, you know, from our center. That's happening in many clinics here in Chile, probably worldwide. And You know, after that, we have the secretary or us have to every day to send a remember email to the patients to say that you have your telemedicine consultation tomorrow at that time. Do you agree? This will be the methods that we will use of the platform. So I think that it is not complicated, but we have to learn very quick how to do this. And the follow-up is easier because usually the patients, when we see the patients and we see, well, we have to the next consultation in 2 months or next month or in 3 months, we give the appointment at that moment. And we have then to remember again, 1 week before and the day before the consultation. So I think it's easier to systematize the consultations in the future, but we have to learn. We have learned a lot in this 2 or 3 months.
The next question is about integrated care. And it's how do we ensure that we can give integrated care in a virtual setting, all team connected to deliver best quality care? That implies, of course, that everybody has to be in on the same consultation. But of course, we can have sequential virtual consultations, I guess. Any comment from the panel? How do you involve the dietitian, the
Yes,
psychologist, etc.?
Probably Agbo want to say something before?
Yeah, I think we can. The way we make referrals, the way we make referrals in in-person consultations.
It's fixed.
Okay, this can also be done. You also be the dietitian that you're sending the patient to the person. So more like clinic to the next person's desk and to the next person's desk. It's still a team.
Yeah, I think that what we do, it's for us probably it's a little bit difficult to have one patient with all the members together at the same time. So what we do is like the same in face-to-face. First is the physician, then we recommend the dietitian, and the patient can make another appointment when the patient wants, and then the psychologist. But I think we always recommend all the teams. I think it's a little bit difficult to have all the teams members together at the same time for one patient, because not all the patients want at the same moment the dietitians, the psychologist.
Now, can I ask a question? Does any of the team have any idea how telemedicine will be used when we eventually conquer COVID-19? Will it change practice? For example, is there a special role for telemedicine in bringing care to areas of the country where there is no expertise, for example? Will it work? And the other area is when we're treating rare and complicated conditions such as Prader-Willi, where there can only be 1 or 2 centres of excellence in any country, can they then be the source for treating the whole country of that rare condition? Do you see a role of telemedicine in the post-COVID world? And how else do you see it operating?
Answering one of the questions here, which is the main challenge of telemedicine, and do you believe this to be a good solution even after pandemic? Yes, it will change the idea of people. I mean, the concept of telemedicine will remain for ages. I think it will continue, and it's now reducing number of visitors of people. People have to wait for a long time. People have to have a very long period of appointments from appointment to other because of the doctors and how can doctor interact. While with telemedicine, I found it's really easy because as a patient, I feel more comfortable of opening a web page and sending to my doctors what I felt at that time, and then he will go and look at it. it will keep a record even. It will keep a long record of what I face. I mean, the doctor, he doesn't have to remember me or he have to open my file at that particular time. As you said, Mr. Rodrigo, it will make a big record, and people will, the doctors themselves and the dietitian, they will not have to go back to it. They will open it simply and they will say, yes, we have been through this conversation, and how it's developed. The patient immediately will just post it and he will just put it in his profile. While now, from each appointment to others, you'll have to wait at least 2 months. And then the doctors have to spend half an hour just to read all what you have done and all your tests. And then again, you have to discuss. And then even if you face any issues in between, you don't have an access to your doctors. Then again, you have to wait for him till the next appointment. But now it's really easy. And in our country, in Sultanate of Oman, they regularize this with some doctors, and they still, it's not with dietitian, but with other doctors, they already regularize it, and they said that it's up to the doctors if he want to go through it. But still, I think it should be a must, and it should continue even after this pandemic.
Okay.
Yes, I think yes. I think that telemedicine is here and will stay, and that patients and physicians and all the team members, we have to learn how to, make it sustainable in the next future, and how, we have to learn, because we started very quick, using technology, but most of us didn't know about this. So it was more a self-learned, how to use telemedicine, how to use these kind of platforms to contact with our patients or with other colleagues, about this. So I think that we have to protocolize, to learn and to protocolize, these consultations for the next future after COVID. This is the pandemic. This is right now what we are doing. This is more a war medicine, and what we have to protocolize in the next future to improve the quality, to improve the satisfaction with from patients and also from doctors. We don't have to forget that there are doctors that they don't like telemedicine at all. So we have to take all together, the members together to the same goal in this. So I think that we have to live with this, and we will get better results in outcomes for our patients.
I think it should have started long time back, but this pandemic, it give us it forced us to start it quickly and to make some even doctor and patient to learn how to use it. Because I remember when the doctors start using systems instead of paper. It was really difficult at the beginning, and doctor have to spend times just to know, even to type what the patient used to say. I've been a patient, and I am a patient, and I'm still going to my appointment. And I found the doctors spend more time on writing what I said than talking to me. So it takes them time. And then now, as they learn how to do it and how to make it faster, even this telemedicine, I think at the beginning, yes, it is difficult. It is difficult to implement it from both sides, from doctor and patient now at the beginning. But I think it have a future, and this is the future.
Now, I have another question from the audience. I think, Rodrigo, probably for you, what are the minimum criteria from both healthcare professional and patients before starting an obesity consultation? What do you need? And if we could talk about video versus audio only, is it the same, or do we need to have video? Can we just do it by telephone?
Yeah, that's interesting. I think that first of all, both healthcare provider and patients, they both need and want to have telemedicine. If one of them don't want telemedicine, it's very difficult and complicated. I have patients that they say, please, doctor, I don't want to use video. I prefer a phone call. And I do a phone call. It's 30 minutes, a phone call, and do the same. You cannot see the patient. It's easier when it's a control and you know the patients before. If it is the first consultation, it's more complicated. I usually recommend and suggest to have telemedicine and video. if it is not possible face to face. So the first criteria is both want telemedicine, the doctor or the team member and the patient. And then what I usually say, listen, if I need at least your weight, your recent weight, if they say I don't have scale, well, but we will need your weight, in some moment of not now, but probably in the next consultation. And if I usually ask some other history, if you have blood hypertension or other metabolic disorder or disorder, to clarify very well, and the medication that the patient is taking. So this reduces a lot, the time you lose asking this during the consultation, and the patient say, oh, I don't know, wait a minute, I'm going to my room to look the medications and show you the boxes. So I usually say, please have all of this, the list, the checklist, for a good consultation. So I think that to make it very, very in a proper way, both have to want telemedicine, and you have to give the patient what is necessary for an improved consultation.
Yep.
And a phone call, I think any method, it's okay. Phone call, video, whatever.
Now, when we normally see a new patient, we take a good history, then we examine the patient, and then we order the tests, etc. In telemedicine, we can't examine the patient. So my question is, what are we missing by not examining the patient when we do telemedicine, and is it important? I have an opinion as well, of course, because I've been thinking about this. One thing is we can't measure waist to hips ratio, but the patient can do that. And we can't feel the liver to see if it's enlarged, but we can order a liver function test. We can send a pathology slip for the patient to have a test. Is there anything else I'm missing that we're not picking up from not doing a physical exam?
I think sorry to just say something, but in telemedicine, you do a lot of patient education, and somehow the patient knows a lot about his or her health. So things like measuring the waist circumference, the patient has to do that. Sometimes, measuring the BP and all the physical profiling, we need to teach our patients to do that. And it also forms part of the conversation when we're doing our consultations, like having the patient do all that. It also ensures that the patient adheres to the daily routines. So in telemedicine, we need to do a lot of patient education on our patients to teach them how to measure certain things. And then for those ones that we cannot measure, we can actually send to tests, to the lab for testing.
Yeah. Probably for control patients is easier because you know the patients before and it's not a problem at all, except if there's something acute occurring in this patient. But for the new patient, for the first visit, it's more complicated. I always say to the patient, listen, this is telemedicine. You can you can measure your waist to hip, you can weight, you can take your blood pressure. This is easier for you if you know how to do it. But I always say, well, but we have in the next, in one of the next consultations, it should be face-to-face. And we have to do, heart exploration, the lungs, and other stuff that we cannot explore in telemedicine. Yes, we can send for a blood test, we can send to an X-ray, whatever, but I think that we have to say it will not only 100% telemedicine from here to the future. We need one face-to-face, in one of the next consultations to know you better.
And I just want to add something as a patient. It's also about the education of that patient. If you are asking him to do a test, such a measurement, and he doesn't even know how to read centimeters from inches, or how to do it in because it's happening. The patients, as you're talking about a patient who's having obesity from the age of 2 till the age of 80. So you have different type of patient who, some of them, they don't know. And even if you depend on others to do it, He might give you three different measurement of the same If you ask him for example, as a hip, he will measure it in a different location, and it gives you different measurement. So transparency is also one of the things which cannot happen in telemedicine.
Dr. Manuel Moreno has asked, any comments about the fair cost of telemedicine? Should it be the same or lower than the face-to-face visit? Should it be cheaper?
Well, I think that this is also a good question. Is related to cost and reimbursement. Usually what is happening here is, in Chile at least, is that the telemedicine is lower priced than face-to-face consultation. You know, and in most cases is covered by the insurance. This is very important because patients want to know how is the cost, is more or less, and if it is covered or not by the insurance. And here it is. Here it's most of the private insurance cover telemedicine. I'm not sure what will happen then after COVID, but during the COVID, yes. So, but it's lower price. I don't know how it is in other places.
Now, in Australia, we have Medicare, which is universal health insurance. And before the COVID, we could do telemedicine with patients that lived out a long way from us in another city. But that patient had to be in the local doctor's surgery rather than at home, which is what we're doing now. During the pandemic, the government has allowed us to do telemedicine with the patients at home. The advantage of having the patient in the doctor's surgery is that at the same time, well, first of all, the doctor weighs the patient and measures the height and takes the blood pressure, the local doctor. And at the same time, the local doctor is learning how to treat obesity, which is a byproduct, which is very beneficial.
Good.
Yeah. When we go out of the epidemic, the government is already being put under pressure to leave the current arrangements here in Australia. I don't know what's happening in the rest of the world, but here in Australia, they're putting pressure on the government to remain as we are now under the COVID, that we can see patients from their own home who are older, either too old to come to us or live too far away. Yep. Now, there's a question here, which patients are candidates for telemedicine? New patients or follow-up patients or both? I can give you an idea. I've been using just telemedicine for the last 8 weeks now here in Melbourne, and I've done both new patients and returning patients, and I've done both video and just telephone. And I can tell you that for obesity management, telemedicine works very well. The patients are very satisfied, even the ones that we do just with telephone. And largely because of the time I take after the history taking to explain to the patient about the biology of weight and why we do what we do, why we do the diet that we do, and all the explanation. And they generally have gone away very satisfied. So you can do both. In my view, both new and returning patients.
I agree.
You agree?
Yes.
Yeah.
Yes. It's easier with when it's one patient, but I agree.
Okay. Now, there's a question here about pregnant women. Would you recommend telemedicine to nutritionally follow obese pregnant women?
Yeah, sure.
Yeah.
I think
Yeah.
it's the same, and it's not a difference, to be pregnant or not. I think, of course, they will benefit a lot.
Yeah, yeah. All right. Now, one interesting solution. Sorry. Go ahead.
Yeah, one of the questions, are the patient tired to answer survey? I'm just asking the patient what if they want, but I don't know if they like that way. Actually, in terms of survey, most of patients, yes, they don't feel comfortable of filling up all type of survey. However, that survey is a minimum thing you can do to really trigger and to find out whether they accept that type of medication. Because see, as a patient, I'm telling you frankly, if the survey is more than 10 questions, I would be really bored to fill up that type of survey, and I won't do it. And I noticed the same because I'm experiencing also sort of diet, which is ketogenic diet with my doctors. And we also start asking, making survey to people. Out of 10,000, I receive only 200 survey filled of, total filled survey. Other than that, most of patients, they don't like that type of survey.
You know what is interesting, that right now we are being bombing, with a lot of emails with surveys for anything, not only medicine, but the supermarket, the pharmacy, your insurance, many. So there are a lot of surveys, and at the end, what people do is, to delete the emails and say, I will not answer anyone. So I think that for our patients with obesity, it is necessary to have the feedback and the satisfaction survey, and probably it's necessary to do something very short, like you say, Mazin, not very big, and only to know a very quick feedback, to improve the quality of telemedicine. And I think this is important. But you have to tell the patient that you will receive this, or you have to send through WhatsApp or whatever, but try to answer, because we are bombing with a lot of surveys, and at the end you see the emails and you see a lot of them, and it's so complicated and so many time consuming.
And most of the patients, they don't like the survey, the type of survey where it is, they have to fill it. And yes, if it is yes, no, neutral, whatever, yeah, that type of survey, it's possible. But when they have to fill what's written in the survey, they found it really difficult.
All right, now we're going to have to wrap up now because it's nearly time. So if we can just finish with the last few words for each of the panel. Rodrigo, would you like to start? Just a summary, very brief.
About, okay, well, I think, is there a role for telemedicine? Yes, there is a role now and in the post-pandemic. Of course, yes, telemedicine is here to stay, and we have to use telemedicine to support our patients for a better control and long-term follow-up. It will not replace face-to-face, but we will have to use technology to support our patients.
Thank you. Ekbo?
Well, for my last few words, telemedicine has come to stay, just like COVID has come to stay too. So I think we should create more awareness on telemedicine and then be open for the changes in future, and also inform our patients and all around us on the use of telehealth instead of in-person visits. We are not cutting out in-person visits, but we are saying that telemedicine will also be an added advantage. Thank you.
I can say
Thank
that
telemedicine
is a must. Yeah, telemedicine is a must, and it should stay after this COVID-19. And COVID-19 actually triggered that it should start it earlier. However, now it's a time to do it, and I think yes, as the doctor says, that it's gonna stay even after the pandemic. Thank you.
Good, thank you. And from me, I think telemedicine has shown us that it can work, and that in the future it won't replace face-to-face, but it will allow us to treat obesity in areas where there's no expertise, local expertise, and it will allow us to treat rare and unusual conditions as well. So we believe that it can be used effectively, that it's for obesity management. And yeah, so thank you very much for attending this webinar, and I hope that you have learned about COVID and obesity and telemedicine. Thank you. Bye. So please complete our feedback form, and you can email us at the email address that you can see on the slide there.